Welcome, everybody, to another presentation from Compliance Reality, where we discuss the reality of compliance enforcement and compliance programs today. Our topic today is standing orders. Don't get knocked down. One of our listeners contacted me and asked for this topic, and I thought that's a great idea. It's something that has been around for a long time. There are compliance issues surrounding standing orders, and it rears its head every now and then. I'm going to share a couple cases where it's reared its head recently, and we're going to talk a little bit about compliance around standing orders. My name is CJ Wolf, and I have over 22 years of full-time compliance experience. I've worked for organizations such as Intermountain Healthcare, the University of Texas System, MD Anderson Cancer Center, and an international medical device company. I hold university faculty appointments in healthcare. I also do private compliance and coding, consulting, as well as training. I am a certified coder. I am an MD by schooling, left that clinical route many, many years ago, and have been doing compliance and coding and those sorts of things, auditing full-time for over 20 years. If you do want to reach out to us, you can see the email on the slide, info@compliancereality.com. Let's jump into the topic. I want to share a couple enforcement cases, and that's going to segue into some of the issues that I think exist with standing orders. This first one was recently in February of 2022, and a medical director was actually convicted. So a lot of times these cases don't go to jury, right? But this one did, and this medical director was convicted for being involved in a $110 million addiction treatment fraud scheme that involved standing orders. The jury convicted this individual for billing private health insurance companies approximately $110 million for addiction treatment services that were not medically necessary. Now, of course, this is not one bill. These are many, many services, but the point is that over hundreds and hundreds of these services, when these services sometimes are up to $5,000 and $6,000, you can easily get up to these types of figures, especially when you're billing multiple private insurance companies. And what was interesting in this case, too, is that it wasn't so much Medicare and Medicaid, which is what we usually see with the False Claims Act. This was private. And the main issues here were performing UA or urinalysis drug testing services that were medically unnecessary for patients who were participating in a sober living facility. The physician also agreed to provide standing orders for these UA drug tests for patients in exchange for a monthly fee. So there were concerns from that perspective as well. But what caught my eye for this particular topic is that it was stated that the evidence showed that the physician did not review the urinalysis drug test results and did not use the UA drug tests to treat the patients. This is a pretty big red flag and a indication that the tests are probably unnecessary. And when you have standing orders, and we're going to talk a little bit about what that means, because some people use that term differently than others. But for now, when you have this standing order that everyone gets these kinds of tests no matter what, they're probably not going to be looking at the results, which tells you that they probably should have never ordered these in the first place. And that was the basic contention here, was that they were just doing these tests standard on everybody, every week, every month, those sorts of things. And so those tests, and they weren't even using the results of the test in their treatment of the patients. Now, this other case comes from the Nevada Attorney General. The federal enforcement agencies were also involved, but this one resulted in a $2 million settlement of allegations, so it did not go to trial. And the whistleblower in this case was a doctor who worked in the practice for over 2 years, close to 3 years. And so the allegations were pretty interesting. And we're going to do a little bit of a deeper dive into this one as I have the court records, and I wanted to show you some things that I thought were interesting. So, first of all, the allegations here were that the doctors, this physician practice, they were fraudulently billing urine drug testing. So again, it's this urine drug test. Now, standing orders aren't just for urine drug tests. They can be for anything that a physician orders diagnostic in nature. It could be an X-ray. It could be a service of some type. So we're going to talk about that, but it just happens that these two recent settlements both have to do with urine drug testing. Also, the allegations included that the physician practice performed definitive urine drug testing on the same day as presumptive urine drug testing. Now, this presentation is not going to be about drug testing, though. That could be a presentation in and of itself. There's been a lot of activity in this area, mostly because the services are deemed as medically unnecessary. But presumptive drug testing, just for our purposes today, is basically trying to find out on the urine specimen, is there a drug in the urine? And definitive usually measures the amount and the types and those sorts of things, more specific type of drug testing. And they were performing both definitive and presumptive on the same day without first reviewing the results of the presumptive test and assessing that individualized need for a definitive test. That's going to become a very important aspect of some of the requirements as we go through these. Other allegations was that included that they were unnecessarily performing testing at higher rates when testing at a lower rate using a different billing code would have been sufficient. So, for example, they were testing for upwards of 22 plus drug classes and types of drugs, as opposed to they probably could have just tested for one or two in some cases. And pertinent to this topic of standing orders, they use standing orders for this definitive urinary drug testing in violation of the Medicare and Medicaid guidelines. Now, what I did is I went into the complaint. Now, again, these are allegations and they settled, so this doesn't go to trial. So this is one side of the story, of course. But this is the complaint. These are, 50, 60 pages that I read through, and I just pulled out some things. So this is what the whistleblower is filing. And this it tells you a little bit of her perspective. It was a female doctor who was doing the whistleblowing, and it kind of gives you an idea of what her thoughts were. She is an anesthesiologist, a pain management doctor, and so is very familiar with the medicine and the science behind all of this. And these are some of the concerns filed in the complaint, that the defendants, the medical practice, these claims that they billed for were not reasonable and necessary because the defendants routinely, number one, caused monthly urine drug tests to be performed and billed for virtually all patients without regard to need. Number two, they tested for more drugs than were necessary, routinely ordering a 22-drug assay as opposed to a lesser and more appropriate drug panel. That's what I mentioned before. And third, they implemented a practice-wide standing order for quantitative tests, that's the definitive test, without first receiving and reviewing the results of the qualitative test, which is the presumptive test. So qualitative means it's the presumptive test. It's almost a little bit like a screening. Is there any drug in the urine? And then the definitive is more the quantitative test where they quantify the amount of the materials. It's more complicated, but for our purposes, that's good enough for you. Now, it's also interesting that they cited, and I'm going to share with you the LCD. Many of you know that a MAC, a Medicare Administrative Contractor, is a local contracted entity that has a jurisdiction over a certain number of states usually to administer the Medicare program in a local jurisdiction. Noridian was the MAC in this case, and they had an LCD, which is a local coverage determination, specifically for drug testing. And they specifically talked about in the LCD, and I'm going to share this with you in a few slides, that payment should not be made for what they called blanket orders for the urine definitive or urine drug testing. 2, for reflex definitive UDT, when the presumptive UDT is performed at the point of care and the clinician has sufficient information to manage the patient. So you shouldn't be ordering more tests when the presumptive gives you what you need. And then third, routine standing orders for all patients in a physician's practice. So I'm going to share with you some of the things here. And you can see we're now moving up in the paragraph count. Their allegation here is that the claims submitted for reimbursement for these patients' healthcare services were false and should not have been reimbursed because the supporting documentation for the testing is not patient specific. That's something I'm going to focus on in a little bit. When the supporting documentation consists of non-patient specific standing orders, payment must be denied. Inadequate documentation precludes reimbursement. Now, some of the documentation that the doctor provided, it was really an interesting read. There's even more than what I'm sharing with you here. But this, or on the left, I know it may be hard to read, but just about every patient's medical record had this type of stuff inserted, not by the doctor, but by the practice, supposedly. And the doctor leadership is what the allegation was. And because the doctor who blew the whistle claimed that she did not personally put this in the medical record, but that it was put in later. And so it appears that they were trying to establish some sort of standard that all patients needed all sort of testing. And what was interesting is what I've put off to the right, which is they wrote in the medical record, all drugs / medications that have abuse potential in our geographic region and that could interact with prescribed medications that have no commercially available presumptive test and or the presumptive test does not meet our stability or sensitivity requirements, meaning they want the pH to be a certain way and this and that, will be tested for using a definitive testing method. This does not preclude a larger definitive panel at the provider's discretion. These specifically today include, and then a long list of drugs. And what the whistleblower said was that in many cases, and in most cases, the patient's history had nothing to do with these drugs. And to test for all of these drugs and she gave examples of a couple elderly patients who had no history of drug abuse, no history of illicit drug use and those sorts of things, were being tested for things that were just too broad. And her conclusion, the whistleblower's conclusion, was if you followed this, you would test for every drug for every patient that ever comes through your door. And her contention was that that's not medically necessary. And to have a standing order that's so broad to say, do this all the time, that's an issue. Now, some of you may be getting your magnifying glass out and reading the fine print over on the left, because that comes straight from the court documents. You'll see other interesting things about how it says, please find attached a copy of an excerpt from our medical group's, quote, best practices committee, end quote, that further explains the rationale for the ordered testing and its medical necessity. Well, the whistleblower stated that there was no such thing as a best practices committee. She had never heard of it. She worked there for almost 3 years, was never invited to it, was never talked about, and contended that this was made up to kind of give if they were ever going to be audited, some sort of semblance of they went through this and they've determined that it's appropriate to test for every single drug under the sun every single time. Again, this is one side of their story. So, found all this really interesting, and that best practices committee policy is also included in the court documents, which was interesting. So, what do the regs say? Well, 42 CFR, you can see the citation there, 410.32, diagnostic X-ray tests, diagnostic lab tests, and other diagnostic tests. So these are for tests, conditions required for when you're going to test some sort of diagnostic test, right? It could be X-ray, it could be a lab test. There's a lot written under this CFR, but I think for our purposes, ordering diagnostic tests. Except as otherwise provided in this section, all diagnostic X-ray tests, diagnostic lab tests, and other diagnostic tests must be ordered by the physician who is treating the beneficiary. That is, the physician who furnishes a consultation or treats a beneficiary for a specific medical problem and who uses the results in the management of the beneficiary's specific medical problem. So it goes on to talk about medical necessity and those sorts of things, but for our purposes of talking about standing orders, it really comes down to when, in order for a physician's order to be valid, it needs to be specific to that patient and their problems and what you're going to be treating. And so what the whistleblower contended in this second case was, look, if a 70-year-old woman has never abused any sort of drug and they may be on an opioid pain medication, why are you testing them every single time for marijuana, for Ativan, for all these different drugs? And that was kind of the contention here, is that the order needs to be specific for the medical problem for that patient, why they're being seen that day when you're ordering that test. And then you're going to use those results. And so in the very first enforcement case, as well as the second enforcement case, they weren't even using the results from the original testing before they'd go on to additional testing, or they never reviewed the results. So it begs the question, what is that really medically necessary? And so you run into these issues when you have quote unquote standing orders. Now let's talk a little bit about what that may or may not mean. So most of you know about the Office of the Inspector General. They published compliance guidance, and they published a compliance guidance document specific for laboratories. Again, standing orders doesn't have to just be labs. It could be other things, but I'm trying to use that as an example. And then you apply those principles in any scenario where you may have standing orders. They concluded in their compliance document, as a result of the potential problems standing orders may cause, the use of standing orders is discouraged. What else did they say? They say that when devising a program or a requisition form for an ordering form or some sort of process for when a physician has to order some sort of diagnostic test, they say you should create a system that promotes the conscious ordering of tests by physicians or other authorized individuals, and ensure that the physician or other authorized individual has made an independent medical necessity decision with regard to each test. So going back to our example of enforcement, why are you ordering drug testing for 22 drugs? Patient has never, been exposed to that drug, is very unlikely to be taking that drug. There's no history or signs or symptoms of that. Why are you ordering that? And so the medical necessity decision has to be made individually for every test, for every patient. And that's why the risk of standing orders can sometimes cause problems. OIG also said, standing orders in and of themselves are not usually acceptable documentation that tests are reasonable and necessary. And then here's that quote, as a result of the potential problems standing orders may cause, the use of standing orders is discouraged. And lastly, from the OIG, they said standing orders, if you're going to do them, standing orders should have a fixed term of validity and must be renewed at their expiration. So now they're using the term standing orders, and I'm going to go through the next few slides about how people use this term differently. And so the point here is, if you are going to have a valid order that may be more appropriately termed a recurring order for an individual patient, it should be for a fixed term of validity and then has to be renewed at that expiration. So keep this kind of in mind as we go through these next few slides. So these next two slides are portions from the LCD that was referenced in that one False Claims Act case allegation. So this is the Controlled Substance Monitoring and Drugs of Abuse testing. So it's specific to kind of this urine drug testing for drugs of abuse. Lots of things are defined here: presumptive testing, definitive. And again, this presentation is not meant to be a urine drug testing presentation. That could be its own. But what I wanted to point out is number 3, specimen validity testing, which is urine specimen testing to ensure that it is consistent with normal human urine and has not been adulterated or substituted, may include but is not limited to pH, specific gravity, oxidants, and creatinine. So keep that in mind. They've defined that. They've defined number 6, standing orders. Test requests for a specific patient representing repetitive testing to monitor a condition or disease for a limited number of sequential visits. Individualized orders for certain patients for predetermined tests based on historical use, risk, and community trend patient profiles. Clinician can alter the standing order. Note, a profile differs from a panel in that a profile responds to the clinical risks of a particular patient, whereas a panel may encourage unnecessary or excessive testing when no clinical cause exists for many of the tests. Now look at number 7 and 8. Some people, when they say the term standing order, they're really talking about 7 or 8. Number 7, blanket orders. That's why in this LCD, they're trying to define their terms. Blanket orders, a test request that is not for a specific patient. Rather, it is an identical order for all patients in a clinician's practice without individualized decision-making at every visit. So in those 2 enforcement cases that I shared with you at the beginning, they use the term standing orders, but according to this document, really what they were talking about there was blanket orders, okay? And then reflex testing. Number 8, laboratory testing that is performed reflexively after initial test results to identify further diagnostic information essential to patient care. This testing is not based on a specific physician's order. Testing performed as a step necessary to complete a physician's order is not considered reflex testing. Now, just for our discussion of presumptive and definitive drug tests, if you go up to number 1 and number 2, you can see that presumptive is this qualitative and the definitive is this quantitative confirmation. So those are kind of interesting definitions too, as a side note. Now on this next slide, later in the LCD, it has a section that says non-covered services. So blanket orders. So I'm going to go back. Remember our definition of blanket orders, a test request that is not for a specific patient. So rather, it's an identical order for all patients in the practice. That's what was alleged in these enforcement cases, that they were just writing these blanket orders. And a lot of people call blanket orders standing orders. So it doesn't really matter what you call it. You can call it purple hot chocolate. But whatever you call it, that's not the name of what you call it. It's what that test actually represents. So keep in mind what the test represents and what the activity of that test is. That's really the important piece. So non-covered services, blanket orders are non-covered. Reflex definitive urine drug testing is not reasonable and necessary when presumptive testing is performed at point of care because the clinician may have sufficient information to manage the patient from that presumptive. Look at number 3. Routine standing orders for all patients in a physician's practice are not reasonable and necessary. And then number 10, you can see that specimen validity testing, including but not limited to pH, specific gravity, oxidants, and creatinine, those are also considered non-covered by Medicare for this LCD. My point in sharing all of this is standing orders is a broad category. It might mean radiology orders. It might mean chemotherapy. It might mean this. It might mean this diagnostic test or whatever. But whatever it is, you need to make sure you're reading the LCD, if there is one, or an NCD, which is the National Coverage Determination, for that test or service. And that is kind of an additional thing to be looking at, in addition just to the general requirements, like in 42 CFR that I shared with you, of diagnostic test orders in general. So now I'm going to share with you a document that is from the Medicare Learning Network, MLN, and this is CMS. This is like a 5-page document titled Complying with Laboratory Services Documentation Requirements. I pulled out a little piece that I think is important because we use terms differently. They said providers should be aware of the various meanings of the term standing orders. Some understand this to mean recurring orders, specific to the care of an individual patient. Others interpret this as routine orders for services delivered to a population of patients. Only medically necessary services ordered and rendered, including those based on treatment protocols, are considered for reimbursement when documentation supports the orders and/or protocols are individualized to each patient. Now, in relation, this is a general nationwide educational piece from Medicare Learning Network. I also then found some interesting documentation. This is why it's important you're following your MAC and looking at that as well. This comes from the MAC for the jurisdictions listed in the lower right corner of this slide. The next few slides all come from this same MAC. It's on their website. And they've defined routine orders, recurring orders, laboratory orders, these sorts of things. So I want to go through kind of those different definitions and the interpretation from this one MAC. Routine orders are orders for those services and treatments that are applied to patients who have the same or similar medical conditions. These, frequently called routine protocol or standing orders, are based on an assessment of the impact of a given condition in the population of patients with that condition, medical illness or injury, and are widely applied to those patients. So when it's widely applied to a population of patients with certain conditions, this is what Medicare said. Medicare defines any order that does not specifically address an individual patient's unique illness, injury, or medical status as not reasonable and necessary. As is required by law, Medicare does not accept such standing orders as supporting medical necessity for the individual patient. Services related to population-based or condition-based orders are not reimbursable. So what they're trying to say here is that it comes down to, are you just saying, look, everyone that comes into your office with burning upon urination gets these 8 tests because we have to rule out this, this, and this? Well, you need to individually make, that may be kind of a general thought process that you're following, but it should not be an automatic set of orders for every patient. The physician, the treating physician, needs to order based off of the medical necessity for that individual patient and not based off of a population-based or condition-based set of orders. Now, that's routine orders. The next is recurring orders. This may be a little different. CMS has not published guidance that addresses how long a recurring order is considered valid. For physician services, Medicare may reimburse quote-unquote standing orders that are specific to an individual patient. Now here's the difference. It's specific to that individual patient. For example, the standing order, quote, evaluate this patient's decubitus ulcer on a daily basis for signs of infection, i.e. drainage, odor, size, and staging, prior to changing the dressing. So that order is something that has to be done every day. Evaluate this patient's ulcer on a daily basis. Okay, that's more of a recurring order. Next, reimbursement of tests or services provided under a standing order for a recurring or serial evaluation is subject to medical necessity review. So it's not in and of itself wrong. It's going to be subject to the facts for that particular patient medical necessity review. All such orders must be written for a specific patient, and each instance of the test or service must be necessary. Each result must be reviewed with appropriate action taken by the treating physician, including any appropriate change in the frequency or duration of testing. So that now we're seeing recurring orders. Okay, that might be okay. In the context of an individual patient, it's reviewed, and each time that is done, it's medically necessary. So it's more fact specific and it's individual patient based. Next, you may hear of what are called treatment protocols. Treatment protocols may be reimbursable since these protocols are individualized to each patient. For example, the use of chemotherapeutic drug protocols that suggest drugs, dosage ranges, frequency, and or duration specifically ordered for an individual patient. This is common in chemotherapy. I was at a cancer center where you had a protocol, and patients with this stage and this kind of cancer, this is the standard of treatment. They should get this much of the drug for the first 3 weeks. They should get this much of the drug for the next 2 weeks. They should then do this for the next week. Then they should do this for 3 more weeks. And so it's a protocol, but it's individualized for that patient. The last 2 slides here that I want to talk about are laboratory orders. Again, this is all from this MAC. In some circumstances, a standing order for a recurring lab test that is specific to the needs of an individual patient may be reimbursable. See again the focus on the individual patient. See the requirements below. It's going to be on the next slide. Pre-printed orders are not covered by Medicare. However, pre-printed or electronic lists of potential orders are permitted if the provider individually affirms, defines, or otherwise modifies each component as appropriate for an individual patient's clinical circumstances. So in other words, you shouldn't just say, oh, this patient has fatigue. Oh, fatigue automatically gets these 82 different tests done. You have to individually think, for this patient, is that appropriate, and that appropriate? Now, here's the last slide for laboratory orders. Standing orders for recurring diagnostic tests may be appropriate when all of the following conditions are met. Each ordered test must be appropriate and necessary for the individual patient's circumstances. Next, the frequency and number of repeated testing must not be greater than medically necessary. Next, the diagnosis must be indicated for each test with sufficient clarity to permit accurate ICD-10 coding to the highest level of specificity. Fourth, the treating physician must review each test's result, making any indicated adjustments in frequency and number of repeated studies. My contention as a clinician, as somebody who's been trained clinically, if you're not going to look at the result of the test, why did you order it in the first place? Okay. It should, for it to be medically necessary, it should then play into your reasoning for the next steps in care for that patient. And then the last one is all lab tests must be reviewed and documentation must support that the appropriate clinical action was then taken. Makes sense to me. Here are some examples. They say examples of appropriate recurring diagnostic tests under Medicare include repeat cardiac enzymes to rule out acute ischemia. If somebody's having chest pain, you do cardiac enzymes at this time and this time and this time, over the course of 8 hours or something. Prothrombin times for a patient on chronic warfarin. So a patient who has maybe AFib or something and they're on a blood thinner like warfarin, they're going to get prothrombin times, which helps the doctor know if the blood needs to be thinner or thicker. Over time, that has to be monitored, and so that may be an appropriate recurring diagnostic test. What if the patient goes off warfarin? Maybe something has changed in their status and they no longer need to be on it. If you have a standing order that patient gets prothrombin times all the time, no matter what, now, if they're no longer on warfarin, you've ordered prothrombin times. What's the medical necessity for that? That's the risk. That's the danger of standing orders, quote unquote, because standing orders can mean different things to different people. That's why we've shared definitions of all these different things. Anyway, I hope this has been something for you to chew on as it relates to standing orders, recurring orders, routine tests, blanket orders, reflex testing, all those sorts of things. If you have any questions about this topic or you like to suggest other topics for us, reach out to us at info@compliancereality.com. And again, if you need help with your compliance program or training or medical necessity audit or consulting and that sort of thing, coding audits, we would love it if you would please consider us, and you can reach out again at that same email. Thank you all for listening, and I will, as usual, make a podcast out of this audio that you could also listen to without the visual of the slides. Thanks for listening, and if you like it, please hit the like button and please subscribe. Until next time, happy compliance.